lecture coming from Dr. Sardar, and he's going to talk about surgical options for patients with Harrington rods, sagittal alignment, and distal adjacent level disease. So we've had some interesting cases in the last several weeks, and we're going to present some of them. And then Dr. Pratt is going to kick us off with a case. And then we also have one case at the very end we're going to try to sneak in from our colleagues. So Nathan.
Good morning, everybody. Nathan Pratt, I'm one of the spine fellows here, finished neurosurgery residency at University of Maryland. I'll show you a case that we actually just did yesterday. So 75-year-old woman came to another surgeon with a T12 burst fracture and progressive kyphosis back in 2020. No reported focal neurologic deficits, just severe low back pain, reducing her ability to sort of participate in ADLs. She had Crohn's disease, osteoporosis. Both of those were significant for her. She had hip osteoarthritis and a hip replacement. Otherwise, other than the physical sort of deformity noted with her kyphotic posture, she was not reported to have any neurologic deficits. This was the preoperative CT from 2020. Outside surgeon saw this progressively getting worse, obtained an MRI showing sort of what you'd expect, compression of neural elements at that T12 level and that progressive kyphosis. So he planned to do a T8 to L3 fusion with a laminectomy at T12. He wanted soft anchors with Mersaline tape used at the top and at the bottom of the construct. Posterior column osteotomy was performed, but he doesn't report a corpectomy or sort of an attempt to restore sagittal alignment. Did not obtain standing scoliosis x-rays. The patient recovered well initially after the surgery, but presented again with worsening back pain after about 3 or 4 months. This was his intraoperative imaging at the time of the surgery. The no pedicle screws placed at T11 at pedicle screws at T11, but none, you can't see my cursor, none above at T10 or T9, just anchors. And then at the bottom, no screw at L1, but put screws at L2 and L3, but kind of a little short there. So this is the patient returning for follow-up. Should pull out of the screws at the bottom at the L2 and the L3 levels. Those rods were palpable and partially eroded through the soft tissue. She had worsening of the kyphotic deformity and had severe back pain at this point. So because of the exposed hardware, the plan was to go back in. He removed the screws at L2 and L3, repaired the dermis in that region. The patient recovered, but was still having severe back pain, and then was seen in our clinic about a year afterward. She's now having debilitating mid to low back pain, muscle spasms. She'd been treated for her osteoporosis with teriparatide, or Forteo, the brand name for it, briefly, but she developed some side effects that were sort of nondescript. So she still has terrible bone quality, but a neurologic exam still normal. She's just completely debilitated. So we obtained a standing scoliosis x-ray. Her SVA was positive, 12.8 centimeters. She has a pelvic incidence of 63 degrees and actually a pretty reasonable lumbar lordosis. She's hyperlordotic at 53.2 degrees, compensating for that focal kyphotic deformity from L1 to T12 of about 52 degrees. Coronally, she's just a little bit, about 4 centimeters off to the left side, and she is retroverting her pelvis a little bit, 29.8 degrees for her pelvic tilt. So our plan for her, given her progressive deformity and significant debilitation, was to go for a thoraco-lumbopelvic fusion and do a T12 corpectomy to try to correct her deformity. This surgery was just performed yesterday, and these are the scouts from the CT scan overnight. showing she's obviously in a supine position for this. So we'll have to see how it looks when she's standing up. But I think it's pretty clear that there's an improvement from this.
So Nathan,
to this. Yep.
go back one more slide. So I was going to ask, we've got some visiting guests here, Dr. Covey and Dr. Martin. So they'd taken her back and then they had taken out the distal hardware on her. What was interesting is that go back to the scoliosis x-ray. So this is a year out and you could, everything had healed, but she was progressively more kyphotic. You could really palpate the hardware on there underneath the skin. What do you guys think, Dr. Martin? So a year out, she's totally healed, and it's was a little hesitant to pursue any surgery.
So I don't know why in the world he left the rest of that hardware in there.
Mhm.
If you're going to take the distal part out,
He didn't even expose it. I think he just cut the rod with a carbide bit because you could see metal scraps in the wound. That his op note seems to indicate that he just opened that one part at the very bottom. And
well, he obviously wasn't real committed to. Well, anyway, the initial construct was doomed to fail. But
yes, we agree.
This is a really difficult problem, and one that I struggle with figuring out what to do. There's a lot of folks walking around like this. Some people are tolerant of it. Some people are not. I commend you all for that was a lengthy surgery, I take it.
Mm-hmm.
And someone who's osteoporotic and 75 years old, those are not, it's not an innocuous procedure.
Well, and we found out intraoperatively she had antibodies in her blood. So she couldn't get normal blood transfusion. So then anyway, her hematocrit keeps dropping. So we got everything done, but yeah, it was a little hairy there for a minute.
So, thoughts on the construct. You have to have some anterior support, which you did. I didn't see exactly what that was.
There you go. It's actually a expandable cage, expandable T-lift cage, expand to about 17 millimeters.
So you kind of went in through T-lift, took the facet joint off, and just kind of came
both sides. Almost like the
yeah.
corpectomy, but it was so collapsed. Rather than trying to put a cage in, it would have been almost impossible to do. Especially given the footprint of those cages, it was safer to try to put and feasible because we were able to condense, collapse upon it, a T-lift cage in there and get pretty good in-plate coverage to get that anterior column support.
So you essentially did an osteotomy, then you cut out the remnants of that T12 vertebral.
Almost like a PSO.
Yeah.
Yeah, it's almost like a PSO here. You can kind of see what we did.
We call it an intradiscal osteotomy. When we just go in and basically stay within the disc space. This one was kind of like a vertebral plana.
Mm-hmm.
Yeah.
So we just had the back wall was really stuck to the dura.
I bet you that was a challenge.
Yeah.
Mm-hmm.
So we had to kind of shell it out. And then I don't know if Dr. Sardar, can you see this image?
Yeah, I see it.
What do you think about the case? And obviously we're dealing with poor bone too. So, her bone quality was not great.
Yeah, just like you guys are talking, these cases are always challenging to begin with. I think the initial construct, obviously, it was inadequate. But I think even from the get-go, if you do a surgery like this, often they end up with a long construct because the bone quality is just not very good, especially with the kind of collapse. So, if it's not something that's urgent, obviously, in those cases, I do have, sounds like she was on Forteo. I do try to have them on Forteo for a few months. Pre-op actually is funny because I had a very similar case, but no one had touched her before. She just presented with everything collapsed, and I did something quite similar as the first surgery. So I kind of agree with your plan. I would have done the same thing. The vertebra there is almost completely flat and gone. So even though you did an intradiscal, it's almost like a VCR there because it wasn't much. It was a sliver of a bone that was just removed, and then same with the posterior wall. And then as you collapse on it, obviously relaxes the spinal cord there a little bit. And then I think proximally as well, obviously, with further imaging, you can see how far up you want to go to, but somewhere in the upper thoracic spine is typically my go-to as well, and definitely down to the pelvis, because no matter what you stop in these patients, where you stop, the lever arm is so long, and it just has a lot of stress that there is collapse distal to that. So I completely agree with the pelvic fixation going all the way down here. So I like this construct. I agree with it. I think the initial surgery obviously is pretty obvious from many aspects was inadequate. I think the number of levels was inadequate, and then just having really a couple of screws above and below and hooks in osteoporotic bone was never going to do it. And then the revision surgery, obviously, it's difficult to really understand what was done. And if you're worried about wound problems, why not take the whole thing out? That whatever was left doesn't make any sense. In fact, the second surgery would have been the surgery that you guys did at this point. So, but she looks good now.
Yeah. Yep. Great. Thanks, Nathan.
Thanks, guys.
So, Jerry, you want to go next? So Dr. Robinson is going to show some other cases. So the other thing that came up, and I was going to ask Dr. Covey, who's visiting us from Tacoma, is, we had, they do all this antibody screening. And what was interesting is her surgery was canceled twice. And so she had already been tested for the antibodies and it was negative. So we didn't really even think about it. And then while we were putting our screws in, they go, oh, she's positive, and she's positive for 2 of them. And by the way, we have no blood. And then I was like, oh my God, so what do you think about, so we're putting in, I think we're kind of halfway putting our screws in.
Well, what made you decide not to stage it then? Like,
well, so that was
an option.
Yeah, so that's what I was going to ask you. So we were kind of, so that was the option. We were going to just put our screws in and then put some rods in. The problem was, and this was an issue, is that we'd gotten far enough along that we would have just had to close without putting rods in, because there's no way we could have corrected that deformity. And so we kind of waited and stalled and irrigated, and then they found 2 units of blood, and then we were able to keep going. But it was just kind of one of those things. I think we would have just closed up without putting a rod in.
It was 20.
Yeah.
Started the correctomy.
Yeah.
And they said they had no blood.
Yeah.
All right.
And you guys were using Cell Saver and TXA?
Yeah. Yeah. Have you guys had that happen to you before?
Thank goodness.
Yeah.
I've had the antibody.
Yeah.
Yeah.
Caused me to.
Yeah.
Delay the case, but yeah, I don't know what else to do.
Well, and the other thing was unusual. Oftentimes, they get this antibody if they get a transfusion. She never had a transfusion. And she had she had her surgery canceled twice. And then so she had 2 tests, antibody tests before that were negative. But it was interesting, just the timing of it and everything. I was just like,
What was her starting
If
grade?
it wasn't hard enough to start.
I think it was 30.
Oh.
Yeah. And she had been, we kind of prehabbed her for like a year. She'd gotten iron transfusion. She'd gotten, seen an osteoporosis person. I mean, she'd
You
been,
found some other, something else to help.
yeah, they were able to chase down 2 units of blood that we could give her. But it was pretty, I mean, we kind of were looking at it, and literally when we put the rod in, it was like pointing towards in fact, we couldn't even get the C-arm in. I had to take the rod out to get the C-arm in because it was so kyphotic. And, by then, once you start dissecting the tissue more and more, it becomes more and more kyphotic, and you're like, geez. So anyways, Jerry.
Good morning, everybody. My name is Jerry Robinson. I'm one of the ortho spine fellows here. I'm going to present a case this morning. So this is a 64-year-old female with low back pain and leaning forward and falling with a long history of multiple spine surgeries, a cane for ambulation, but severely limited currently, has right lower extremity pain and some numbness, but no weakness. Here you can see their long surgical history. Back in 2006, an ALIF with peak cages, pain pump insertion afterwards, likely for worsening pain, and adjacent segment disease. Eventually went on to a T10 to pelvis that eventually failed and required a revision for T3 pelvis due to PJK. Had some chronic wound drainage and eventually had an IND with the removal of their left iliac screw. So here you can see their exam, neurologically intact other than some hip flexor weakness, but sensations intact. Infectious labs were normal at this time, so it looks like they did heal their wound. They had a DEXA of -2.6, but they were on Forteo for a year. Here you can see their coronal malalignment leaning off to the right side, lumbar lordosis of 30 degrees with a PI of 75 and an SVA of around 11, 12 centimeters. Their ODI at that time was 84. CT myelogram, for completeness sake, showed a solid posterior fusion mass and a solid anterior fusion mass with vacuum disc above, no malposition screws, no stenosis, and preserved upper instrumented vertebrae +1 and no PJK. So at this point, do you want me to continue on with what we did here?
So just really quick, I wanted to get Dr. Sardar's.
This is a different one that you originally assigned me.
Yeah, that's fine. It's
other
fine.
problems.
Yeah. So we have a hard time, and I'm sure you don't have this problem in New York City, but getting really good scoliosis x-rays in these patients. What do you guys do at your center? Do you guys have an EOS or?
Yeah, we get EOS for all these patients. Pretty much before surgery, everyone gets EOS. Even our smaller fusions will get EOS before surgery just to kind of get it. And even cervical, I typically get EOS to see what the overall alignment is like and to make sure that the deformity isn't somewhere else. So we get EOS, and then as a routine again, this patient pretty stiff with the previous instrumentation in, but typically we also get supine films, scoliosis supine films to see what kind of flexibility they have for those who may. This one probably not going to have any flexibility, but that's a protocol typically.
Yeah, so I think these are the full-length x-rays we got. Unfortunately, we're not as advanced as you guys, Dr. Sardar. We're working on getting the EOS, but I think that's the future, is to get full length, look at the legs, look at the hips.
It's funny that you mentioned the full length for looking at the legs and everything, but that'll come in play later. But basically, the patient went for a T9 to pelvis hardware removal, removal of the posterior pain pump catheter, revision instrumentation, T7 to pelvis, leaving the proximal junction alone, and then 2 asymmetric, coronally asymmetric PSOs at L4 first, and then I think an additional one was used at L2, and then plastic surgery closure. And here was our final construct with multiple rods and improvement in the sagittal alignment there. So you can see if we would have had that technology, we would have been able to know that the patient did have a leg length discrepancy, left greater than right, which was contributing to their coronal malalignment, but much improved alignment here. And there you can see the patient actually went for a staged OLIF at L1-2 2 months later, and removal of that anterior pain pump. You could see that there was a large gap disc here that went for the OLIF. And they're walking upright and neurologically intact with their short-term follow-up and no wound breakdown.
Let me ask a question. Quick question. There's a big difference in the coronal alignment here compared to the previous post-ops that you showed. Was that just positioning, or did something change in between with the OLIF?
I think it was believed that the patient did get I think it was like a 2 centimeter shoe lift. So I think that did help. I don't know if you mean that you can tell that there's a difference between like the pelvis and the spine. They kind of looked here to me to be symmetric, just kind of tilted over from the right lower extremity shoe lift.
And then the first stage, you guys, it was just a removal of everything to kind of let the infection cool down, and then went back again for the PSO, or was the PSO done at the same time?
So the patient was proven to be negative for infection and had a healed posterior wound. They had previously had an IND with removal of the left iliac screw and long-term antibiotics. And so at that point in time, they were felt to be quote unquote healed from their infection. So we proceeded with the entire posterior plan here, before moving to the staged O-lift 2 months later for that anterior gap disc.
So I think this was one of Dr. Hart's cases. And I agree with you, Dr. Sardar. I think, what was interesting, go back to the pre-op, is that, this is a case, I think, where really if you have EOS, you could see how impaired she is. And she's so, I think, her main issue, again, I never saw her before surgery, but seems to be coronal more than sagittal. But obviously she also has a flat back and has sagittal imbalance. The difficulty, I think, in these cases are, where do you end it distally? And then, is PSO the, right decision in terms of trying to correct this? Because it's so hard to, and where do you do it? Let's see the post-op again. Yeah, I mean, I think, do you do it in the upper lumbar spine or do you do it down lower where she really needs the lordosis?
Yeah, I think it was originally done at L4 and then wanting to get more correction, then it was up at L2.
Yeah, I would say my bias typically is just kind of working with Dr. Lenke. Our bias typically just is to start with the lower PSO. So usually, again, and sometimes if they've had a T-lift or whatnot, it makes it a bit difficult depending on where you're approaching from. But if an L5 PSO is possible, then oftentimes we'll do an L5 PSO because that's where you get the biggest lever arm correction. That flagpole just kind of tilting everything to the side that you want it to be. Or L4. So L4 or L5 PSO is typically, for these severely malaligned patients is kind of my choice of PSO level. But it sounds like obviously you guys need more correction and then ended up doing a second one.
Yeah, I mean, I think, Bob did a great correction here. I always have a hard time with PSOs because it's hard to intraoperatively, assess your correction. And again, sometimes, you want to do more, you get less. Sometimes you get more and you want to do less. They're not always, they don't always go as planned, but this looks beautiful. Great. So we'll see how this thing heals because obviously with, PSOs, the pseudo rate is pretty high. And I see that there's
multiple rods.
Multiple rods there.
Yeah, there's the rod-to-rod connectors with an outrigger rod, and then there's the dual rods, the quad rods below that at the PSO sites.
Great. Great,
Cool.
thanks,
Thank you.
Jerry. So we tried to, Dr. Sardar, we always try to get like cases that are, related to what you're going to talk to. So we tried to get cases that had surgery and are having issues.
I appreciate it. These are great cases.
Yeah.
Hi, I'm Zach, neurosurgery spine fellow from Canada. This is a quick case. This is a patient who was done earlier this month. As a 73-year-old lady, she's had numerous revision lumbar surgeries for chronic back pain and leg pain in the past remotely. Her last surgery was laminectomies, and she's currently got a posterior instrumented fusion from L2 to L5. Her most recent surgery was a T9 to 11 laminectomy in 2019, done at another hospital because of stenosis above her construct level. She has 3 years of worsening back pain and right leg pain in an L5 distribution, and weakness associated with it on the exam.
Ben, can we get the slides? I think they're having trouble seeing the slides online.
Can everyone see the pictures?
You can see him. Yes.
Okay.
Great.
So she's in a lot of pain. She's ambulatory, can't make it around the block just with a walker. This is her pre-op imaging, showing her previous fusion and kyphotic deformity above it, which you can see more clearly on the CT scan. This is her cervical spine, which was not her problem. I just thought the osteophytes were interesting. This is a CT myelogram of her entire spine. Shows her laminectomy site from T9 to T11 in the middle sagittal slice, and the kyphotic deformity associated with that. And then her lumbar spine, which shows robust fusion from L2 to L5 and autofusion from L1 to L2, and numerous areas of stenosis and foraminal stenosis.
So what was her main issue, Zach?
Her main issue was back pain, hunched over deformity, and right L5 severe radicular pain.
Okay. And do we have some upright images? Those were it.
Yeah, these are her
Okay.
uprights.
So not horrible.
Not horrible.
Yeah.
But I think,
But she looked pretty tight. Is it L1-2 or L2-3?
yeah. And also down below, I couldn't get a good foraminal slice, but she had foraminal
5-1.
stenosis at 5-1.
Okay.
Yep. So she was taken to the operating room earlier this month. T8 to L1 laminectomies, fastectomies from T9 to T12, posterior 3-column osteotomies at T11, 12, T12, L1, instrumented fusion from T4 to pelvis. Surgery took about 8 hours. She lost about 2 liters of blood, got 3 units, but her correction is, I think, pretty nice. Those are the pre-op films and the post-op films. If you can see, she had a coronal imbalance tilting off to the right a little bit, and looking at her coronal intraoperative films, you can see we eccentrically placed cages at T12L1 and put 2 symmetric rise cages at 11-12 to try and correct her coronal deformity, which seems to be straightened out pretty nicely in the coronal standing films. Patient did really well, went home on post-op day 5.
So just a quick learning point, and I don't know if Dr. Covey or Dr. Martin want to comment on this, but I always get nervous when I see 2 hip replacements and you're going to do a big deformity surgery. Is there any things you guys do before operating on someone like this to try to optimize their kind of rehab and potential issues afterwards?
What's the concern about a hip replacement?
So I've had, and I don't know if this is just in the last several years, we've had several patients who had anterior hip dislocation after having a deformity surgery. And again, I mean, it's kind of like having a patient like this where they have, and it's usually the ones that aren't really that far off. You're not doing a major correction. It's the ones that are a little bit, you do a little bit of a correction here and there. But I've had 3, and I know Jens has had at least 3 or more.
Yeah, I don't do these,
Yeah.
but I've just never had a good understanding, even still looking at it and trying to figure out, even with, again, we talked about that earlier. I mean, you need to look at the, from the feet up to the head, and, a couple of degrees of, retroversion of the acetabular implants side is going to make that more likely to pop out of the front. And I try to get these patients to do, prehab and get them stretched out and work on their hip flexors that are always tight and their hamstrings, which are always tight. But most of the time, nothing comes of it. So like I said, I'm not surprised that it happens, but because I'm not doing this, I don't see much of it. Do you see anything else? Yeah.
And I don't know if Dr. Sardar, what your thoughts on it are, but I think the coronal issue isn't the problem. I think it's more sagittal, where you're pulling them back more. So your hips, you're changing the, I'm not an orthopedic surgeon, but you're changing the hip and the angle of, so you're extending your hips. And so do you think that's what causes, do you guys know what the reason for the hip dislocations are after deformity surgery?
Yes, actually, it's been written quite extensively now, and it's even for patients that have short segment fusions to the pelvis. So even if someone is at L4 to S1, they do have a higher rate of dislocations of the hips, and part of the few different reasons. Obviously, number one is that they lose a bit of the compensatory mechanism because now their lower part of the spine to the pelvis is not really moving, so the hip takes more movement, and so that's part of the reason. The other is, for patients who don't really know if it's necessarily associated even with major corrections or not. But we do think that, for patients where you're increasing their sacral slope, effectively you're increasing the anteversion of the hips. And, some of those patients, as you kind of decrease that coverage of the hips, can dislocate. Interestingly, there was a study, I think not so long ago, where they looked at Medicare patients, and they actually found that patients who had lumbar surgery in the past and then had hip replacement had a higher chance of dislocation compared to those who had a hip dislocation first and then had the fusion surgery. So there's a little bit of, because I was surprised when I read that. I would have thought the other way around. But even if they've had the lumbar surgery first and then they have a hip replacement, they have a higher chance of dislocating the hip. And I think part of it is obviously the shape of the version of the pelvis changes, but also because they can't compensate as well. There's no more movement there, so it takes more, I think, movement out of the hip, and that's why they dislocate. As far as what to do differently, unfortunately, I don't think anyone has an answer that I've come across so far. I mean, we are aware of this problem now, but we don't know how to fix it or what to do about it. I think is essentially what it is. Some of these patients, like was mentioned, can have tight hip flexors, and that can be prehab, but oftentimes they don't, and they can still dislocate. So I'm not sure how we reduce that risk of happening.
And you wanted me to just run over Chrome real quick, or no?
Yeah, why don't you really quick? So
Okay.
The other thing, Dr. Sardar, we're going to show you is we're trying to come up with a nomenclature system for multi-rods, and Dr. Tataran worked on this research project. So he's just going to present it very quickly.
Yeah, just super quickly. We just submitted this to Global Spine with all of the current fellows as co-authors due to their dutiful help. And this is just a quick elevator refresh, actually an initial refresh for everyone. Just for a consistent nomenclature rod, like how would you describe this construct in 5 seconds to another fellow spine surgeon? It'd be tough to do. There's no consistent nomenclature. So it'd be helpful for medical lingo. So we came up with the Chrome system, classification of heterogeneous rods for multiple etiologies. And it was a 4-digit score. Number of rods, how high does the rod go? What was the reason for having more than 2 rods? And is there more than 2 sites, or is there more than 2 pelvic fixation screws? So it came up to a 4-digit score. And essentially we just tested all the fellows. We gave them a set of these 10 slides and a little refresh on this scoring system. So we just went through all of these slides, gave all the fellows 30 seconds each slides to apply the Chrome score, and then repeated that a month later to get a final statistics, intra-relator reliability. Turned out to be pretty reliable. And we just submitted it to Global Spine. So hopefully it really picks up and everyone adopts the Chrome score.
Great. Thanks, Zach.
That's all I got.
So Jared Cook's going to present another revision case. But I think, by doing this multi-rod nomenclature, I think it'll hopefully also, surgeons will try to decide, when to use 4 rods, when to use 2 rods. I think right now it's just, I don't think there's a real consistent way of trying to figure out what the nomenclature is. So I think that's a great project, Zach. So Dr. Cook's going to present a difficult Charcot patient.
All right. So this patient, we're going to start from the beginning. Initial presentation was to an outside surgeon when the patient was 29 in 2017. Complaints seemed to be low back pain, bilateral lower extremity weakness. There's a history of a T5/6 spinal cord infarct at age 15. But from the documentation, it's very unclear the etiology. It basically had just an op node and nothing else. But according to that, the inflammatory markers and white count were normal. And this is what they saw there on their initial X-rays. So you have that L1/2 disc space collapse and the anterior inferior body of L1 erosion, and then also up at T11 that you can see. So here's the MRI at the time. So we have pre and post contrast. So looking at this, their working diagnosis at this point was osteodiscitis, and so that was what the patient was treated for. So they had that L1/2 posterior decompression and fusion, and it was noted in the surgeon's op note that it was more likely Charcot than infection, and they got negative cultures out of it. So then the patient.
So he's wheelchair bound.
Wheelchair bound.
Yeah.
I think there was some history of using some ambulatory aids. Considering what his neuro exam was even after that. He had enough strength to to use some sort of assist. I couldn't quite gather what they were referring to, but at this point, when he shows up here, he's in a wheelchair. And continued weakness, bilateral lower extremities. So, here's what things are looking like at that time. So this is just, 6 months after he had that first surgery. And so there's, further degeneration at this level, or further destruction, should I say, at this level. Getting some coronal deformity there. This is what you see on CT. And then also the level noted above is also continuing to fall apart. And so the patient was taken for a T5 to pelvis fusion in the first stage, and the second stage was L1 to L3 X lifts, because really this patient with that Charcot really needed anterior support there. And so this was the correction, the best images for the scouts. And then, here's coming in about 6 months later. So at this point, there's some screw loosening, the bilateral iliac screws. The rods are intact so far at this point. Then a short time later, a few months later, the patient, feels a pop, and here we go. Feels a pop when getting into his car, having right leg numbness, progressive pain, kind of going up the leg into the buttocks. He was doing better with his strength, but now he's completely confined to the wheelchair. Been trying a bone growth stimulator, and then at that point, there is a dissociation of the rod down here. There's a rod fracture that's hard to see on the other side. More screw loosening, even the revised iliac screws. And so at that point, the plan was to revise the fusion again and put interbodies from L3 to L5. Notably, this patient doesn't have much of an L5S1, has transitional anatomy down there, and revising the loosening iliac screws. So this was what the final construct looked like at the time, and the patient just kind of disappeared for about 3 years.
No, I mean, we go back. So I think, one of the difficulty in this case was, I think, we probably should have done, and this is actually my patient, inner body fusion. And he just didn't heal his lumbosacral junction. And you can see, although he fused at the level of the Charcot, I think, looking back on it, and again, he kind of, if you looked at his, I thought his, he kind of had a pretty solid posterolateral fusion. But then he wasn't we did lose him to follow up for a couple of years. But then he showed up when he heard a pop in his back. And then this is what we ended up doing. And then I saw him recently in clinic, and I think we're ordering a CT scan. I don't know if we have that at all.
We don't. So basically what happened is that he disappeared for a couple of years, and then, felt that pop in his back again, and, showed up to his primary, and his primary said, hey, maybe you should go and, see the people who treat this. And so he finally, made it back to the office, and his new CT is scheduled for 2 weeks from now. So unfortunately, we don't have the new one. Basically, came in with a corrupted file, so we can't get much other than the scouts from it. So we're just rescanning. That's basically where we are.
Yeah, but Dr. Sardar, I don't know if you can see the scout there, but it looks like he fused. I just saw him in clinic. It looks like he's fused at L5S1, but I'm not sure it's totally healed at L45. And the Charcot area looks like it's healed, but he's wheelchair bound, and it's always, the pelvis lumbosacral junction in these longer constructs can be really difficult to get to heal. Do you have any, let's go back to the original, and I think he'd had previous abdominal surgery. He had something as a child, I can't remember what, but doing an ALIF was going to be a challenge. What do you think about this case, Dr. Sardar?
Yeah, obviously challenging case. I think, as we know, Charcot patients with a Charcot spine, healing becomes a problem, and that's probably why you went back and just did those excerpts to begin with to get that to correct. But again, I think in patients who have Charcot spine or insensate levels below a spinal cord injury, and then fusion to the pelvis definitely puts them at a high risk of pseudoarthrosis. So may have considered doing a TLIF at L4551 just to begin with, especially considering the history, like you said, of prior anterior surgery that would have stopped you from doing an anterior approach formally. But I think these are challenging cases anyway, regardless of, even if we did TLIFs to begin with, long lever arm, Charcot spine, non-ambulatory patient who typically, as they ambulate, they put a lot of torque on their lumbosacral spine because they're using a lot of that torquing type of movement to try to do whatever ambulation they can, or limited ambulation and movement. So I think these patients, I think this patient had a few risk factors. One is Charcot, second is a long fusion to the pelvis, and third is a non-ambulatory status. Actually, patients who are totally wheelchair bound are probably better than who are kind of a little bit mobile. So this patient is like in that where he wants to get up a little, but then uses a lot of probably torque on his spine that increases that stress. So I mean, he does have a lot of some risk factors for the non-union. So I think the only thing I would have maybe considered differently is just doing a TLIF to begin with, but still has a high risk, I think, of non-union.
Dr. Arlay, what are your thoughts on, I see your hand up. Good to see you.
Good to see you. I don't know if you see me, but anyway, so I can hear you pretty well. This fantastic cases you're showing. Just I'm between cases. I'm between the front and back, as a matter of fact. So I'm still waiting for the positioning of my patient. Yeah, the fantastic cases. So for the Charcot patient, it's very challenging cases, and I think right off the bat, these patients, I do 4 rods, and right off the bat, I go antibody in the front, all the lumbar spine, and even in alpha coronal junction, when it can add antibody, even instrumentation in the front as well, and on the top of the cages, if there's a room for that, I do it. it's very challenging.
You've gone from would you have done an ALIF on him, Dr. Arle, to begin with?
At 5'1", yeah, and 4'5", yes, because a Charcot patient without any antibody fusion at 4'5", 5'1". So I understand he had previous abdominal surgery, but work with somebody with a good access surgeon. So usually it's not a problem to get to go back and revise previous anterior abdominal surgery. It's a problem if there was previous access to the spine. Well, there was no previous access to the spine anteriorly. Usually you find a way to get to the spine. Whether you use a right side approach, left side approach, or oblique approach, you always have a way to get to the spine if the spine was not approached anteriorly.
And how about for the Charcot level itself? What would you have done differently? Do you think you would have done a lateral corpectomy?
I think just what you did, it was good. I would probably have added a rod in the front at this level, just a plate and screws in the front. At the same time, I don't do much true X-lift. I'm more anti-psoas kind of guy. So when you use anti-psoas, you can just put a plate. You put your cage and then you put a plate on the top of it, or a couple of rods with the screws, so that makes it a bit stronger. So
I remember, Dr. Arle, when I was a resident in Virginia, I think you did the first multi-rod case with Frank Shen, and I think I was a resident. It was like a lumbo-pelvic fixation you guys did.
Yeah.
If you remember that.
We published about that 18 years ago. Double rod construct, which I think the history, I thought it was very painful to do it. So I did a few and then I stopped doing it. But Frank Shen was more perseverant. He continued to do it. And me, after a while, I had so many broken instrumentation and that I went back to Frank Shen to do this adult scoliosis with 4 rods. And my go-to in adult scoliosis, I put 4 rods because there's so much broken instrumentation that we see afterwards. So that I go with 2 iliac screws on each side. So, and this mitigates a little bit the broken instrumentation. Yet I saw 2 weeks ago a patient I had put 4 rods 4 years ago and broke the 4 of them.
Oh my God. Geez, you're gonna have to present that case.
So he's a very tall guy, huge, heavy set, and broke the 4 rods.
That's tough. And then we were going to present, Tarek, are you online? We had a case from Pakistan. We're going to present. I don't know if we can.
I don't see them on yet.
Oh, you don't? Okay. All right. That's fine.
It's Rod. If I go back to dislocation of the hip, I just raised my hand, but obviously that moved. There's one thing that overlooked very often. We always talk about the anatomy, retroversion of the pelvis, anteversion of the cup, and vice versa, anterior hip dislocation, posterior hip dislocation. But one thing, all these patients who had extensive lumbar surgery, they often have L5 weakness that gives obviously control of the abductors. So on the top of all the anatomic geometric parameters that exist and explain the hip dislocation, the abductor weakness of this patient is there. Is no question about this. They have abductor weakness because they have L5 radiculopathy and because they had multiple hip surgery or just previous hip surgery that was give them abductor weakness. So that's something you can check before if they have a positive Trenenborg gait or not. Because the patient has already a Trenenborg gait before you construct, you're sure it's going to be more likely to dislocate than if it doesn't have a Trenenborg gait.
And then how about, Vince, what about if you, so Jens and I've had this, what if you did a beautiful reconstruction for someone, they dislocate, and what do you do? Because there's always this, do you have the hip replaced or do you go back in and do something in the spine?
So I had a few hip dislocation like you, and the last one, which was a problem, my hip partner, Charles Nelson, did a fantastic job. he put a semi-constrained hip, and that from that time on, the patient did not dislocate back again. So maybe that's a solution to revise the hip. I'm not sure to revise the spine is the answer, okay, unless it's a really the spine is a mess, so there's obviously a complete malalignment. But most of the time, it's the spine is acceptable, and so it's more in the hands of the hip surgeon than in our hands when it happens.
Yeah, great. Thanks, Vince. So we have so Tarek, we have about 10 minutes. We have Dr. Tarek Sohail and Dr. Ghalib from Pakistan. How are you guys doing?
Well, fine. Thank you very much, Rod. We have a presentation ready. Whenever you say
that'd be
yes,
great.
go ahead.
We're excited to see it.
Oh, pardon? What did you say?
Yes, we're excited to see it. Thank you.
Start. Okay. Dr. Ghalib, Khizr Ghalib, he is a senior star in a hospital, and he is going to present one spine surgery case with a neurofibromatosis. It's a very interesting case. I'm sure you will love it. And by the way, Rod, these are your three beautiful daughters. I must say they are absolutely fantastic, gorgeous daughters.
Thank you so much.
Like you. I'll request now Dr. Khizr Ghalib to come online and present cases. He's a young, talented guy who's doing surgery with us, and he's very keen on degenerative and other kind of surgery, and he's now learning ropes of endoscopic surgery in most of the indications. So without any delay, I request Dr. Khizr Ghalib to present his case. Khizr.
Great.
Thank you very much, Dr. Tarek. Good morning, everyone. I'm Dr. Khizr. I'm working as a senior registrar in orthopedic department of Lahore General Hospital. I did my spine fellowship, a one-year fellowship from Pakistan Orthopedic Association in 2020. So coming to the case, we had a young male, 14-year-old. He came to us with pain in his thoracolumbar junction. And can you hear me? Am I clear?
Yes. Yeah. You're coming in nicely.
All right. So this young lad, he had pain in his thoracolumbar junction, and it was aggravated whenever he stood or he walked, and he looked like he was pretty thin and lean looking. He had multiple Kyphosis spots all over his body and multiple subcutaneous neurofibromas. There was a kyphotic deformity at the dorsal spine junction, and the patient had a slight forward bending posture, and the sitting and standing coronal balance were well maintained. So this is the kid. So if you look at him, we can very clearly see the Kyphotic spots and the deformity and even the neurofibromatosis. And if we look at the sitting balance, he's quite balanced. Even the standing posture is good in the coronal balance. These are the radiographs. In the radiographs, we can clearly see the kyphotic deformity and the transposition or the translation of the dorsal spine. And if we look closely, we can see the pencil ribs and even the scalloping of the vertebral bodies, which tells us that it is a dystrophic neurofibromatosis spinal deformity. So our diagnosis was painful kind of complex spinal deformity due to dystrophic neurofibromatosis 1. So if we look at the sagittal balance, the SVA was pretty much in the acceptable range, and the other pelvic parameters were not so. So this is the pre-op 3D CT scan, and here we can see the vertebral bodies lying next to each other, just like the kissing vertebrae. In the 3D reconstruction, here we can see that the D9 vertebra is pretty much rotated, and it's lying side by side with the D10 vertebra. And even the D8 vertebra is in the same line to some extent. So here again, we can see the anatomy on the CT scan. The vertebrae are lying side by side. So on the MRI, we can see here that there is, again, the vertebrae are lying side by side, and there is dural ectasia at the level of the deformity. And there's also maybe a double sign that can be a dural neurofibroma. So MRI of the lumbosacral spine, it was pretty much normal. So we tried to classify this, and the only classification that I could find was by Isaac Aguirre in 2018. And according to this classification, they classified it into 4 types. And our patient was falling in the category of type 3, which is gamma. Here we can see type 1, classified by Isaac, type 2, which is basically an omega deformity, type 3, a gamma deformity, which is our patient, and type 4, which is an alpha deformity. So here, the CT scan of the 3D reconstruction of our patient. So it is a type 3 gamma deformity. There is complete vertebral position in the sagittal plane at D9-10 level. And this curve type, it can only be appreciated with a 3D CT scan. A normal CT scan or a simple X-ray won't tell you the gravity of this deformity. So principally, this deformity occurs in the sagittal plane, and the coronal plane is pretty much normal. And the final measurements of these angles, which is important, which was told by Dr. Isaac in his classification, was they give 180 degree of angulation to all these cases in which there is complete transposition. So if we have an angle of 53 degree of local angulation, we add 180 degree into it, and the total. So what are the surgical goals? They remain the same. We have to restore the mechanical alignment, decompress the neural elements, negate the pain generators, obtain stable mechanical fixation and biological fusion. So these are the per-op images. We will see that we have the holding rod, and then from the right side, we have taken out D9, part of D10, and also part of D8. We actually went both sides, but the picture is only of the right side that we have. So per-operatively, the surgery time was around 5 hours. We had a blood loss of 2300 ml, and after performing the VCR, it was quite negotiable in coronal and sagittal planes. And there was an iatrogenic pleural cavity puncture, which we repaired, and we didn't have to pass any chest tube. And the post-operatively, the left-sided lower limb had a weakness, motor power weakness of 3/5, and the sensations were pretty much good. So these are the post-op radiographs. Here we can see that it is well aligned, both in coronal and the sagittal planes, pretty much acceptable. These are due to the motor power loss. We went in, we sent the patient for a CT reconstruction to see if there was any mispositioned screws, but everything was normal, and the patient improved the very next day, and so we didn't take him to surgery for any further decompression or any looking. So these are again the post-op CT scan. The screws are in pretty much good positions. So these are the post-op patient pictures. These are 1 week after the operation, and the patient here, if we look at it, all right, so I think the video is not working. So the patient was pretty much walking with a little limp due to his motor power of 4/5 in the left lower limb, which improved in another week. So thank you very much. This was a short case.
Great. Thanks so much, Dr. Maleeb and Dr. Sohail. That was an excellent presentation. Were there any changes in the neuromonitoring during the case?
Well, unfortunately, we do not have neuromonitoring here in our setup. So all we rely on is the visibility of the dura in front of us. So as you must have noticed that we like to have wide laminectomies so that we have the dura in front of us while we are manipulating it.
That's a great case you guys just showed. Thank you so much.
Just a comment, if you guys don't mind.
Yes, Zeeshan?
Well, thank you, Dr. Zahir and Dr. Ghalib. So typically for these patients, obviously you guys don't have monitoring there, but even in patients who have significant deformity and we cannot get signals, usually what we do is we'll get multiple wake-up tests. Obviously that makes the procedure longer, but that gave us some information during the surgery itself. So at regular time intervals, typically initially just after positioning, after screw placement on one side, then the other side, and then at some point during your laminectomy as a reduction. So unfortunately, multiple wake-up tests is one way to get around not having motors. Obviously, that adds a lot of time. So I think you have to factor that into it.
Yes, we do the wake-up test, but not multiple times. Usually just once after manipulating the cord. And if we have any problem with that, we just take out all the rods and leave the screws in and come back after 2-3 weeks.
Zeeshan? Zeeshan?
Yes, listening.
Yeah, I think since we have a very heterogeneous kind of facilities, we didn't have the monitoring at that place. But having said that, everything was exposed, and moreover, the dural sac and the cord was just lying in front. And once it stabilized on one side, we went on the other side and removed the bone, and just went right across and made some kind of translation possible to restore back to normal alignment, and keeping an eye on the cord so that there's no excessive stressing or manipulation or angulation there. So I think it's just I would say absence of neuromonitoring, but having a great faith in Almighty, and it did work. But we are planning to have a neuromonitoring equipment very soon. But having said that, we maintained the anesthesia department, maintained their good blood pressure. MP was well within normal limits, and he didn't have any. 2300 was a estimated blood loss, but at the same time, he was given transfusion more or less of the same magnitude, and he never had any hypertensive episode or so. So practically, he didn't have any neurological problem, which one could see that. There was some transient issue, but that resolved within a few days, and the patient is up and about without any issue. He's very happy with his trunk appearance and overall appearance and ability to walk straight and see straight and without any problem.
Great, thanks.
The outcome looks really good.
Thank you very much, Zeeshan, and thank you.
Yeah, so we're gonna transition to our next portion of our spine conference, and I'm going to introduce Dr. Sardar. Dr. Sardar is a spine surgeon at Ock Hospital in Columbia, and today he's going to talk about doing corrective surgery on patients who've had adjacent level disease. Welcome.
Thank you very much, Rod. Thank you for having me here. And it's good to see some familiar faces here as well from Pakistan, and Dr. Arle. It's nice to see them. So I'm going to talk about surgical options for treatment of distal lumbar degeneration and sagittal malalignment in patients with prior Harrington rods. Just a bit of an introduction. As we know, Harrington rods were quite commonly used in the 1960s to 80s, and even in some patients in the early 1990s. This is a picture of a Harrington rod. It's based on a distraction type of mechanism that allowed for decent coronal correction. But as we have seen over the years, it was not that great for the sagittal plane. It commonly resulted in flattening of the instrumented spine in the sagittal plane. And then many of these patients we have seen back with flat back occurrence. that results in a problem. And so we'll focus on some of these issues. There's a nice study actually that I saw from 1995. Didn't come across a lot of similar studies, but this summarized the problem very well. And so they looked at about 43 patients who were instrumented distally to different lumbar segments, to L1, L2, 3, 4, and 5. And what they saw was there was a progressive decrease in the lumbar lordosis as the lower instrumented level was more distal. And they also saw a compensatory increase in the remaining segments that were not fused. But as the lower instrumented level moved more distal, often that compensatory increase in lordosis was not enough to make up for the loss of overall lordosis. And so here is a table that they showed that if your lower level was L1, you actually gained a little bit of lordosis, but as you went from L2 to L5, you lost a significant amount of lordosis through the lumbar spine. Now here's a graph representing the same. As you can see, patients who were instrumented down to L5 or even L4 lost a significant amount of lordosis compared to the pre-op lordosis. And this one is showing the change in lordosis through the segments that were not fused. And so if you're fused to L1, the remainder of the segments are able to hyperlordose a bit. Actually, if you fuse down to L3, that's where you get the most compensatory increase in lordosis from the remaining segments. But as you keep on going distal, the compensation, there's a limit to how much the remaining segments can compensate to make up for the loss of lordosis. And so this is a good summary slide showing an increase in the overall sagittal malalignment as the distal or the lower instrumental level became more distal. So especially patients with L4 or L5 segment as a distally instrumental level had a really positive sagittal vertical axis, and so these are patients that we end up seeing a lot of later on because of these issues. So I thought I would present a few cases of patients with Harrington rods that I had to do revision surgery on to go over some of the key concepts that I look at when we revise these patients. So here's a patient of mine, a 70-year-old female with worsening lower back pain and left leg pain. She's gone through all the typical non-operative treatment in the past, but continues to have significant back and leg pain, limited in terms of her ability to walk due to the pain, and also reports that it's difficult for her now to stand up straight. She says that initially after the surgery, she was doing pretty good. She did pretty well for many years, but over the past 10 years or so, gradually, it's been difficult for her to even stand up properly, stand up straight. So here are your PA and lateral images, and you can see that coronally, she's not that malaligned. She's slightly malaligned towards the right side. There is a lumbar curve that's not fused. The instrumentation extends down to the L2 level. And then in the sagittal plane, you can see the thoracic spine, most of the thoracic spine has a Harrington rod, and so it's quite flat. And then below that, distally, you see degeneration at essentially each level of the lumbar spine. I typically measure or will assess malalignment in the sagittal plane just based on the cranial axis as well. And so that's the line you see here. But in terms of parameters that we look at, you see the lordosis is only 12 degrees, while the PI is 50. So the PI-LL mismatch is quite high of 38 degrees. The thoracic kyphosis is only 8 degrees. But the SVA still is about 60 millimeters. So the patient does have some sagittal malalignment. Rod, we were talking about this earlier. We do get EOS films in all our patients to see what their lower extremity compensation or alignment is like. And you can see here that this patient, if we just looked at the initial film, she doesn't look that far off. The SVA is 60. It's a little bit positive, but if you look at the full length films, you can really see how they're trying to compensate by bending their hips and knees and even ankles. But she's still not able to really, fully stand up straight despite implying these mechanisms. So there is a fair amount of sagittal malalignment that we can pick up here. And then, as I mentioned, I do get supine films on all these patients to assess for flexibility. So here's the scoliosis AP or PA supine, and then we also have the lateral plane supine. And the supine is important because it allows us to look at how much flexibility they have. And this is a zoomed in version of that supine film and shows a bit of vacuum disc phenomena at each of these levels. And when I measure the lordosis, it shows that it went from 12 degrees in the standing to about 30 degrees in the supine position. So it's already looking quite good to me that if I can make the spine a little bit more flexible, I'll get the lordosis that I want. And so just like in most of our patients, we get CT reconstructions, and we also look at the 3D reconstructions to just visualize things better. We can see she has a significant amount of foraminal stenosis here on the left side. That's probably why she's getting that radicular pain in the left side, in the left leg. But she also has some foraminal stenosis on the right at the apex of the concavity of the lumbar curve. And so the MRI shows the same findings. You have foraminal stenosis on the left side of L5S1, but then on the right side at L4-5 and L3-L4. So far, what I'm considering is that, well, this patient does need more lordosis because there is sagittal malalignment. There are 4 discs from L2 to S1 that are not fused. So potentially I could do posterior column osteotomies to get a bit more flexibility. But already by just standing here in a supine position, I know that I can go from 12 degrees to about 30 degrees. So there's an 18 degrees of extra lordosis I can get just by positioning her the right way. She does have different levels of stenosis, so I have to decompress that adequately. And then the apex of her lordosis is at L2, L3. If you look at the PA, she's slightly malaligned coronally, but not horrible. But she does have a bit of a remnant thoracic curve. And so with these, I cannot make the lumbar curve completely straight because then she would be coronally off a lot towards the left side. And that's an important consideration to look at many of these patients, that you almost have to match the fused curve as opposed to totally straightening out the curve that's left. So here is a CT 3D representation of what this patient's spine looks like. The other challenges in patients like this is with previous fusion mass, especially with Harrington rods. These patients have had surgery 30, 40 years ago. They typically have really thick fusion masses, and your landmarks are almost non-existent. So the different ways to figure out where to put the screws. If you use navigation or robotics, you can do that. Or in many of these cases, if I'm not using navigation or robotics, I'll actually take a printed 3D model with me to the case to identify where the starting points of these screws are going to be so that I can put them appropriately. In this case, in most of my cases now, I use some kind of enabling technology. So here we did plan out screws prior to the case so that I can avoid the rods with this that are existing there. And so kind of place the screws around the pre-existing rods. So then actually the other interesting thing I saw just from planning of the screws was that if you look at the contour of the rod that the simulation is giving me, the 2 rods are of different shapes. And that's because obviously there is rotation in the lumbar spine. And like I said, in this old patient with the lumbar scoliosis and a bit of a remnant thoracic scoliosis, I wasn't planning on completely derotating the spine or completely correcting the lumbar scoliosis here. So I did have to plan for a different contour of the rods as well. So we did that. We planned, and I do a lot of pre-op planning. So we actually planned 2 different shapes of the rods for the different sides to, again, maintain a bit of the curve and not completely correct it. Another key point I know we talk about in deformity, we talk about PI-L mismatch a lot. The key in this patient is that her thoracic kyphosis is only 8 degrees. So she's not like any normal person with a normal thoracic kyphosis. So if I matched her PI to, or her lordosis to her PI, she would be severely negatively imbalanced actually in the sagittal plane. So we actually planned for a lordosis of around in the 30s to get her better aligned, but not all the way match the lordosis to the PI because her kyphosis is quite low. So you have to take that into account. And sometimes it's difficult. It's kind of difficult for me to visualize those things. And that's also why these type of simulations help me visually kind of seeing just where the patient is going to end up being. And so, when it comes to execution, we're thinking of, we already planned out the screws and rods and how much correction we need. And so now in terms of execution, to get the most we can, positioning is extremely important. So I put these patients in open frame Jackson. I put the pads a bit more distally to get more lordosis just from positioning. We had already planned PCOs, or post-coronal osteotomies, from L2 to S1, as opposed to a bigger osteotomy, just to get a bit of a harmonious correction. And then, decompressions as we planned, and T-lifts at the bottom, just because there's more stress at the base. So typically I will do in these deformity cases at least 4-5 and 5-1 interbodies for the fusion. And so this is my, once the screws are in, once the osteotomies are done, once the decompression is done, then rod placement is extremely critical to really get the correction. So these are the movements I go through. Typically, I'm thinking about the coronal and the sagittal plane at the same time. And so in this case, starting at the lumbosacral junction, we know that we have to balance the lumbosacral and the coronal plane, but also get more lordosis from it. So I started off actually on the right side because I wanted to compress on the L4-S1 on the right side to balance L4-S1 in the coronal, but also increase the lordosis. So initially started off at the lumbosacral junction on the right, and then kind of left it there and went over to the left side. Now, at this point, we have locked in the sagittal plane from L4 to S1 to get more lordosis. Now I can distract on the other side to, again, even out a little bit, the L4-S1 coronal curve. And then we continue up on the left side again, because I'm going to compress on this side, on the left side, to get more lordosis from the upper levels. And then at the same time, cantilever the rod down to connect into the upper fuse segments. And then once, at this point, the sagittal plane is essentially locked in. And then we just basically drop the rod down further up on the right side to capture the remaining screws. At this point, typically by this point, you still have a bit of this concavity left. And so this is where I use a third rod to translate the whole segment over towards the right a little bit to get a bit more coronal correction. And so this is the typical rod maneuver. I do get films intra-op, essentially full-length films intra-op, AP and lateral, to see really what kind of correction I got and if it matched what I wanted to get. And I typically measure the lordosis, and I was pretty happy with what I got here compared to where I started from. And I also get coronal or PA films to see if you're balanced coronally. So if you look at the T-bar, it looks like it's balanced, but really it's not, because I wasn't really, my T-bar really wasn't on the hips properly. But if you balance them on the hips, because I could see that I actually overcorrected this patient a little bit. I was actually, initially she started off being malaligned towards the right, and now she's off to the left. And that's actually what I was concerned about in terms of overcorrecting the lumbar curve. So we actually went back and compressed approximately a bit more on the right side and distracted a bit on the left to get this patient to be a bit more balanced in the coronal plane as well. And so this is the overall post-op AP and lateral. You can see she's well balanced in the coronal plane and also in the sagittal plane compared to pre-op. Parameters, we got a pretty good amount of lordosis, but still mismatch is 13, but that's what she needs. If we got more than that, she'd be overcorrected. And then full length films really show the change in that compensatory mechanism, that she's not bending her hips or knees or ankles anymore. She's standing up quite straight. And so she's not stressing her joints as much. So she was pretty happy with that. Another case, similar but slightly different, because this patient is actually fused down to L4. And what we saw from that initial paper I presented is that these patients don't have a lot of compensation, and typically these patients start off even from the get-go with the positive sagittal malalignment, and that's exactly what this patient reported. She said, pretty much since the surgery, most of her adult life, she's been unable to really stand up straight without bending her hips or knees. And so she does have a PILN mismatch of about 18 degrees. But in her case, the difference is that the kyphosis is closer to 33. So she does need to be, the mismatch needs to be a bit more optimized in her case. And you can see her standing extras again. And because she's fused more distally, she's a bit more positive, and her knees and hips are bent. She's trying to compensate a lot. And so here, same thing, I tried to assess flexibility, but really wasn't much that I got from L4 to S1. Similar, the 3D CT shows that there is a really nice thick fusion mass posteriorly. L5-S1 is completely collapsed, but there is a disc at 4-5. But then if you look at it more carefully, there are discs at the other lumbar levels as well that potentially could be used. And so there are different options in this type of a patient. I'll skip through a little bit. This is an interesting patient because you could you need more lordosis, and essentially you have L4 to S1 that's not fused. And so essentially you can do anything here. You could do an anterior approach followed by posterior, where you get really hypolordotic cages anteriorly, or you could try you could do a PSO posteriorly, or what I did in this case was I actually cut the rod and I cut through the fusion mass to do more posterior column osteotomies higher up in the lumbar spine as well, because the discs were not fused, to get again a nice harmonious correction. Typically, for most of these cases, there is not a need to extend proximal in the thoracic spine, because usually they're not symptomatic from that, and the rate of PJK is not that high. And so this is, again, we kind of planned our screws around the rod. I did cut the rod, and I did end up doing posterior column osteotomies from L2 down to S1 with, again, T-lifts at the bottom. And this is the correction we got. A lot of lordosis just by doing the posterior column osteotomies and posterior interbodies. And again, you can see very nice alignment in the coronal and sagittal plane. She's well balanced. This is another one of those patients. She's 50 years old. She doesn't really complain of difficulty with standing upright, so she's a little bit different. She mainly complains of pain. It's pain in the lower back, and she actually has pain in the upper back as well. And so there's a bit of a remnant curve with the lumbosacral junction, and you can somewhat appreciate a bit of maybe junctional kyphosis up top. So this to me is more of a degeneration as opposed to really a deformity correction, even though it's multiple levels. So she did have pain higher up here with some degeneration in the discs and facets. She has pain lower down. She has some radicular pain. Obviously, you got the MRI scan to look at different things, and the rest is stenosis. But the decision here was simple, that she didn't really need much in terms of osteotomies or corrections. She basically needed to maintain her alignment, and I did extend. This is one of the very few cases where I extended higher because she had a lot of degeneration and pain at the upper levels as well. And so this is again the correction that we ended up with. Again, it's important to be careful with the lumbosacral curve in the coronal plane. If you overcorrect it, you can throw the patient off balance in the coronal plane. But she is really well aligned. Here's a case that I actually did before I moved back to New York and before I had EOS. And so you can see again, long Harrington rod going down to L4. She only had L4 and L4 to S1 that was not fused, but she had difficulty standing upright. And so again, you could do anterior approach, whatever posterior. You could do a PSO here, or you could do. I could have cut the rod and done multiple posterior column osteotomies. In this case, I ended up doing an anterior L4 to S1 with hypolordotic cages, followed by just a posterior, essentially instrumentation and fusion without much of an osteotomy at all. And she got really good realignment and was happy with that. And then I'll present a final case and leave some room for questions. And so what if you need more correction? And this is really where then we start to talk about bigger osteotomies and things like that. And so here's a patient who presented to me. I think she was also in her 50s with, you can see a Harrington rod almost all going all the way to the sacrum, but the hook is dislodged at the bottom. A severe sagittal malalignment. We cannot even get her in one EOS film here. And then additional to that, she also has coronal malalignment. You can see there's valgus deformity of her knees to try to compensate so that she can stand upright. So quite deformed patient. Twin swept knees because the coronal malalignment, really flexing the hips and knees because of sagittal malalignment, essentially fused all the way down to L5. So the only level that was not fused were L5S1. And so this is the patient where I decided that I would do a PSO at L5 to get as much correction I could get from this one level that's not fused. Again, we could have broken down many of these levels, but you could see her discs are not that tall. There is maybe some anterior fusion in many of these. So instead of spending more time at multiple levels, this is the patient where I thought a 3-column osteotomy would serve best. And so that's what we ended up doing. Ended up doing an L5 PSO in her. Can't even count how many rods I have in her. We did put 4 iliac bolts. Again, whenever I do a lower lumbar osteotomy, I put 4 iliac screws or S2AI screws and multiple rods. Multiple rods in her case just to kind of line things up properly and also to really stabilize because everything was really hinging at the L5 PSO. But you can see how she is still not perfect, but a lot better than what she was before surgery. She can actually stand up and look at people at their face. And you can also see even coronally, she's actually a bit better, and that the valgus deformity is not as pronounced. It's still there, but not as pronounced of the knee. So a lot better alignment. And so this is kind of how I decide what to do for these patients. You know, obviously you go by what their problem is and if they have a malalignment or not, and if it's mainly back pain or radicular pain. But after that, you know, I do try to assess what the magnitude of the deformity is and how flexible these patients are. And then it's important to see how many of those discs that they have left, how many are unfused or how many are fused. If a patient has multiple discs that are unfused, then typically it's easy to do multiple posterior column osteotomies and interbody work, whether anterior or posterior, to get them aligned. If they only have 1 or 2 segments left, then it really depends on the malalignment. If they're not malaligned, if it's more of a degeneration, then again, you could do interbodies and essentially fuse them to get rid of their pain. But if they have moderate malalignment, that's where I found that anterior A-lifts or O-lifts can help a lot. But patients with severe malalignment, that's where we end up doing a 3-column osteotomy. So this is not a simple kind of flow to figure out what to do for these patients. Just to sum up everything, important to assess the magnitude of deformity and flexibility. Try to use any segment that is not fused so that you could get a better harmonious correction as opposed to a sharp angular correction. Planning and simulation can help a lot. Some patients need a 3-column osteotomy, but most of them don't. We pay a lot of attention to decompressing wherever, even if they're not symptomatic, but decompress those segments so that they don't end up with arterogenic stenosis, especially foraminal stenosis, as we try to give them more lordosis. And then rod placement technique is important, so you know where to start from and what sequence of compression distraction we're taking. And for all these patients, you know, it's very easy that they become a bit more malaligned in the coronal plane. So I always get intra-op films to fine-tune that before we leave the operating room. PI-LL mismatch, like I said, in some patients with Harrington rods may not be as applicable because they typically will have very low thoracic kyphosis. And so that rule doesn't 100% apply to them. Many of these patients, as you guys have treated probably as well, they have really weak bones, and it's not uncommon that I'll have them on some medication for treatment of osteoporosis or osteopenia prior to surgery. And I've seen some failures from other places where they kind of don't instrument enough into the fusion mass. And so as a general rule, just like a long bone, I try to get at least 6 fixation points into the prior fusion mass. So that means at least 3 levels into the prior fusion mass. And usually you don't have to extend proximal to the Harrington rods except for in rare circumstances. So I'll stop right here and see if you guys have any questions.
That was terrific. Do you use it looked like you were using, what sort of preoperative? So you use EOS. What's your workflow? And then do you do robotic? Are those robotically placed?
Yeah, so my workflow, I mean, typically for most of these cases now, I do use robotic place screws, and that makes, honestly, putting screws through fusion mass is quite easy. And also just pre-planning the fact that we're going to avoid all these instrumentation that's already in place. So I use robotics to plan everything. It also allows me to plan how my rods would go in, so that I can plan for more straight rods and not have to bend rods in the coronal plane as much. And then I do use, for correction and rod, I do use pre-bent rods according to the plan that we come up with. So that again, that kind of takes that headache away. So I think a lot of it, honestly, is done pre-op. The screws are planned pre-op, the rods are planned pre-op, the correction is planned pre-op, and then, intra-op, you're just executing that plan that you already have in place.
I mean, I think, we've had cases like that, and the fusion mass is just unbelievable. It's like it's like one big solid piece of bone. And I do think, between the robot, pre-planning, I think that really makes a huge difference, because the screw placement is can be really challenging.
Yeah, absolutely agree. That
Yeah.
almost takes that stress away. It makes the screw insertion part really easy. And then you can focus on the osteotomies, the other work that you have to do. But honestly, it's just autopilot at this point that you don't even have to think about the screws as much because the technology now is quite accurate and you can easily place those screws without having to think about it. Before I started using the robot, I would take a 3D printed model with me and mark on it where I'm going to put the holes and use that as a guide to put the pedicle screws. Because there is no landmark, like you said, they're just a big one sheath of bone. There's no landmark.
Well, that was a terrific lecture. We really appreciate the insight and the cases and your experience, especially with the robot. I think that's the future, I think it's only going to get better and better. We just needed to take call and do clinic. That's the only thing. I'm trying to get the companies to think about that.
Yeah, I mean, again, I guess every place has a value proposition, but for us, it's definitely helped, especially for these type of cases. I mean, it cuts down, I think, the OR time a lot, so there is a saving definitely there. I think in terms of return to the OR, that's still a bit debatable because what you end up doing is you end up spending more time in the OR to be more careful to place those screws. So it's not. I don't think it's necessarily that you'll have more revisions or less revisions, but I do think you save a lot of time if you pre-plan. I mean, honestly, the screw placement becomes the easiest part.
Yeah.
Whereas before that, it used to be one of the bigger challenges.
And how many robots do you guys have now at Columbia?
We have two.
You have two. Which ones? Do you have the Medtronic and Globus or?
Both Medtronic.
Both Medtronic. And just one other quick question is, so how are you incorporating EOS in the pre-planning? And do they all get CT scans as well?
Yeah, so there are two ways so as far as the robot is concerned, you could either get a CT pre-op and then use fluor to CT, or you can do CT intra-op and do a scan plan. My flow typically is that all my patients get a CT pre-op anyway, because again, I want to look at the pedicles or previous defects and all those things that you guys look at. So I typically get a CT scan anyway, and so I make sure that CT is compatible to the robot protocol. And so then I will plan all these screws beforehand. And as far as the EOS and pre-planning the rods and everything is concerned, we get EOS films, and then the EOS films are actually sent to the platform that they use the EOS films to plan the rods and correction. And often I will also actually transfer over my robot screw plans to for the rod planning as well, so that they know exactly where my screws are going to be, and so that we can plan the correction and rod placement according to the known placement of the screws. So, I mean, it's not publicized as such, but in many of my cases I use it. And like I showed you one case where I kind of ended up with a differential contouring of the rod, and that was based on the fact that when I planned the screws, you could see the rods are going to be just very different shapes. And then they were able to use that concept to make differently shaped contoured rods. So I think that helps a lot. At the very least, I think just planning that with the EOS and having those pre-bent rods to your plan gives you a confirmation intra-op. That if you can just put the rod in and you without having to bend it, you know that you're pretty close to the target that you wanted to achieve.
Well, thank you so much. It's great to see all the great work you guys are doing over there, and look forward to having you more involved in our courses here in Seattle.
Well, thank you very much. I appreciate the opportunity to present. Thank you.
Okay, take care, Dr. Sardar. Thank you, everybody.